Here's the last thing we're going to talk about is treating bipolar depression, and it's tougher to treat than unipolar depression. It's very different. Metabolically, it's different, and in terms of response to medications, it's obviously different based on everything I've been talking about. This is what you see classically with unipolar depression over here on the right-hand side. Very significant, widespread changes, especially decreases in metabolic activity in most parts of the brain. There's a few parts of the brain that are hyperactive, but most parts of the brain are hypometabolic. But you can see the bipolar depression in the middle, metabolically, is just quite different. The problem is that they share some symptoms superficially, and that's why there's a lot of misdiagnosis. No, APA guidelines do not recommend antidepressants, okay? Switch rates in this large study that I mentioned briefly before, 5,000 patients, 37% have reported a history of switching, and we had like 43% had a history of cycle or 23% history of cycle acceleration. So anyway, antidepressants are not a good idea. Okay, so what do you do to treat bipolar depression? Well, there are 4 medications that have relatively good efficacy in treating bipolar depression, and here they are. And lithium has to be at least a blood level of 0.8 or it doesn't work. If you read some of the literature that goes back a few years, they'll say lithium is not effective, but what was discovered is a lot of times they were using lithium in doses that yielded blood levels of 0.5 or 0.6. So the problem wasn't that lithium didn't work, it's just they weren't using high enough doses. Now, if you take a look at these, 3 of these drugs have something to offer, and that is they're also anti-manic, okay, which is good. So if you have bipolar 1 and you're going to use a drug that decreases depression, you certainly, it would be nice to have a safety net there in case the person overshoots and gets into mania. So that's part of what drives some of these treatment guidelines. Now, lithium typically is not a first-line choice for treating bipolar depression for one main reason, and that is side effects. It's got a ton of side effects, and you've got to do a lot of laboratory monitoring of blood levels, and you have to watch thyroid function and kidney function and so forth. So it's not a user-friendly drug. It's on the list, but it's generally not first-line, mainly just because of the side effects and difficulty with prescribing. This guy has Stevens-Johnson syndrome, and this is what our patients are going to see, or the parents of kids that are on Lamictal, get on the internet. Stevens-Johnson syndrome is sometimes referred to as a rash, but it's much more than a rash. It is a severe immunologic reaction, and it has been found to, in the initial studies, it would occur in 1 out of 1,000 adults and 2% of children. And the problem with this is that it can kill you. And when people develop this, even though they have aggressive, heroic attempts at medical stabilization, still 50% of these people die from this. Okay, and typically when it starts, it has a relatively sudden onset. It's very different than ordinary rashes. Most rashes you get with psychiatric medications are hives or kind of reddish, itchy rashes on the arms and torso. This almost exclusively affects things from the neck up, and you can have hives and you can have rash with it, but as you can see, at some point start bleeding from eyes and nose and mouth. The skin on the inside of the cheeks starts sloughing off, and again, it can kill you, okay, and it progresses very, very rapidly. And but there's some good news about this, okay, and I'll tell you what the good news is, and that is what they found is that if you dose this in a way where you start with very gradually small doses, then you can basically avoid Stevens-Johnson in teenagers and adults. The issue about children is still a great concern. And so this particular dosing strategy is mandated now with Lamictal. Okay, but one of the points I want to make, let me go back here for just a second. Lamictal can be a lifesaver. It's a really very good drug for treating bipolar depression and rapid cycling, but because our patients have access to the internet, a lot of times people get on there, they put the search search engine Lamictal, and they'll get these pictures, and it scares the living daylights out of them. And who wouldn't be scared? What, my kid's on, my 18-year-old daughter's on this? Forget that. Okay, so anyway, here's the original data I talked about. Now, in Germany, they have socialized medicine there, and they have what are considered to be the best data on rashes. And it has something called the German Rash Registry. And I want you to know something. Germans take these rashes very seriously. Okay? You don't mess around in Germany with rashes. In fact, in Germany, if you're a physician, if you prescribe any medicine and there's a rash, even if it's just a benign rash, you have to report it or you lose your license. Okay? Yeah. So internationally, people say, if you want epidemiology on rashes, go to Germany. Go to the German Rash Registry. Okay? So anyway, here's the deal. Since they started this gradual dosing strategy, okay, now this is not children, okay, but these are teenagers and adults. You can see here that benign rashes that occur really with all these drugs. You can get, hives or something like that. A little bit more drug than placebo, but not significantly different. If you look at serious rashes, and there are other kinds of serious rashes occurring with very low frequency, a little bit more with the drug than with placebo. But there have been no cases of Stevens-Johnson seen in teenagers or adults, and this is over the last several years. So it's really a non-issue. In children, it was 3 out of 10,000, and that's still, I wouldn't go there with kids. But you're going to see kids, you're going to see 10-year-olds that are on Lamictal. Okay, and the reason is when nothing else works, sometimes this works. Okay, but that level of risk is not enough for FDA to come in here and jerk it off the market. But it's still saying there is some degree of risk with kids. All right. Now, the other drugs, Symbyax, Seroquel, we talked about before. Okay, I'm going to run through this quickly, and I want to mention to you that this is in the process of change. This is the current treatment algorithm, guidelines for treating bipolar depression, but I'm going to tell you that it's going to change probably within the next 12 months. And I'll tell you what the changes are. Okay, first off is if the person has bipolar 1, then what are the treatment recommendations? And by the way, this comes from the, you have your practice guidelines here. This comes from the Texas Medication Algorithm Project. Okay, now, currently, it says Lamictal and an anti-manic drug. This is absolutely a good reflection of what happens in research, and that is what is held to be the truth or the current version of the truth is subject to change with more research. Since this came out a couple of years ago, there's new data that shows now that Seroquel is actually probably better than Lamictal. Okay, so you take a look at this, but what's going to happen almost certainly is when they revise it this summer or next fall is Seroquel is going to go into first place because it's simply better in head-to-head comparison with Lamictal. Now, a part of the reason Lamictal is up here is because it's effective. The other part is it's very, very well tolerated, okay? Why would Seroquel take the first place? Not only is it good, but it's also got a built-in anti-manic agent, okay? Remember, it's an antipsychotic, it's anti-manic. Therefore, because of its efficacy and the fact that it prevents mania, it's a very good choice for first place, all right? And this is also the case with bipolar 2. Lamictal is recommended as number 1. Bipolar 2, the big difference is you don't have to worry about manias. Okay, so what if you provoke a hypomania? Hey, have a good time. Okay, take a break. Take 2 days and have some fun.